Welcome back to the Deep Dive, where we take your curiosity and turn it into clarity. Today, we're embarking on a fascinating journey into, well, one of the most delicate and geometrically intricate areas of the human body, the neck. Specifically in the context of thyroid surgery. You sent us some incredible questions wanting to understand the secret pearls of thyroidectomy, those crucial triangles that guide a surgeon's hand, and the strategic decisions behind neck dissection for thyroid cancers. Our mission today, to give you a real consultant-level understanding. Strip away the overwhelm, leave you with those aha moments that make you feel truly well-informed.
It's a fantastic topic. It really is. Full of nuance and incredible precision. What's truly fascinating here, I think, is how much skill lies not just in removing the disease, but in preserving everything vital around it. We've poured through a stack of sources, detailed surgical pearls, strategic guidelines to really map out this complex landscape for you. It really makes you wonder, doesn't it? How do surgeons navigate such a crowded space? So many critical, unforgiving structures packed in there. It's not just knowing what to do, but how to do it with such exactitude.
That focus on preservation seems absolutely paramount. Could you walk us through how that translates into the surgeon's actual approach? Like from the initial incision, what are those critical steps? Steps that ensure that meticulous care, specifically regarding avoiding those vital structures? Because, yeah, when we talk about thyroidectomy, it's clearly not just about taking something out.
Exactly. Our sources consistently emphasize that the core principle is this balance. Balancing oncologic clearance, getting all the cancer out with functional preservation. The true art, the real skill, lies in achieving that radicality where needed while meticulously preserving key structures.
Yeah.
It's fundamentally about ensuring the patient's long-term quality of life isn't compromised by the very surgery meant to, well, save them.
And this is where some of those memorable sort of consultant aphorisms really come to life, isn't it? Like in thyroid surgery, what you don't injure is more important than what you remove. That really drives home the precision involved.
It absolutely does. Just think about the recurrent laryngeal nerve, the RLN. It controls your vocal cords. Injury there can lead to anything from hoarseness, a complete loss of voice even, or severe breathing difficulties if both nerves are affected. It's serious. Then you have the parathyroid glands. Tiny little things nestled behind the thyroid, essential for calcium regulation. If they're accidentally removed or their blood supply is cut off, devascularized, it can cause hypocalcemia.
Hypocalcemia, that's low calcium, right? Leading to spasms, tingling.
Exactly. Muscle spasms, tingling. So surgeons live by principles like never guess the nerve, always see the nerve, and a nerve seen is a nerve saved. These aren't just clever sayings. They are non-negotiable rules for patient safety, really. Even the external branch of the superior laryngeal nerve, the EBSLN, which controls voice pitch, is critical. Injury to that can mean a singer can no longer hit high notes, or a teacher struggles to project their voice. It impacts their profession, their daily life, profoundly.
Okay, so if we follow that path, what does that level of meticulous care actually look like in the operating room? How does a surgeon ensure that precision at each step, starting from the very first cut?
Well, it begins right from the initial incision. Typically a Kocher's collar, that classic, usually pretty inconspicuous incision along a natural skin crease. From there, the surgeon gently raises the skin and the layers beneath it, often called subplatysmal flaps. They lift them up towards the sternocleidomastoid, that big muscle on the side of your neck. The whole goal is to always stay incredibly close to the thyroid capsule itself. This capsular dissection is absolutely key.
Tell us more about capsular dissection. Why is staying so close to the capsule so critical, especially thinking about cancer?
Right, it's the main principle for avoiding injury, yes, but it has a deeper oncologic purpose too. It's about achieving complete capsule removal to prevent it from rupturing. Imagine the cancer cells contained within the thyroid, sometimes right up against that capsule. If you breach that capsule during surgery, well, you risk spilling microscopic cancer cells into the surgical field. That significantly increases the risk of local recurrence or even distant spread.
Ah, so it's not just about protecting healthy tissue nearby, it's about keeping the disease contained within its natural barrier.
Precisely. Surgically isolating the disease, maximizing oncologic control. It's especially critical in cases like follicular neoplasm or papillary thyroid carcinoma. Beyond that, it involves individually controlling each feeding vessel, especially at the superior pole, meticulously dissecting and ligating or cauterizing them one by one. This isn't just about stopping bleeding, It's about systematically undressing the thyroid for its blood supply while keeping everything clearly visible and avoiding heat spread to nearby nerves. And then, down at the inferior pole, gentle mobilization is key. You have to avoid any traction injury to that delicate recurrent laryngeal nerve. Postoperatively, this vigilance continues, immediate voice checks, being on high alert for complications like a hematoma, blood collection.
Which in the neck can be really dangerous, fast. Airway issues.
Exactly, an airway emergency. Even something like a chyle leak where lymphatic fluid escapes can happen in lateral neck dissection. It just shows how expensive the risks are if things aren't handled meticulously.
Wow. That really brings the art behind this precise work to life. Okay, now, this is where it gets really interesting, especially for those of you who asked about the triangles of the neck. You wanted to know how surgeons navigate this incredibly complex area, how they define these crucial spaces. It's not about the thyroid being a triangle, right? But about the triangles around it that act as essential maps.
Precisely. Think of these anatomical triangles and angles not as abstract geometry, but as vital landmarks, like signposts maybe, or specific highway exits. They guide the surgeon to safely locate nerves, vessels, other structures. They're absolutely essential for precision and, frankly, avoiding critical errors in a space where the margins for error are almost non-existent.
So let's start with that all-important recurrent laryngeal nerve again, the RLN. Its preservation is so critical. What specific triangles help pinpoint its location?
Two key ones really stand out. First, there's Baer's triangle. His boundaries are the trachea of the windpipe medially, the innominate artery or vein inferiorly, though admittedly this lower boundary can be quite variable, and the carotid sheath laterally.
The carotid sheath. That's the tunnel with the big artery, vein, and nerve.
Correct. Common carotid artery, internal jugular vein, vagus nerve. The relevance here is that the recurrent laryngeal nerve runs within or very near this triangle. It makes it a safe sort of entry point to search for the nerve. Think of it as a reliable zone for that initial nerve identification.
I can picture that. Okay, a reliable zone to start the search. And the second triangle.
The second is the Baer's-Kocher triangle. This is a classic teaching concept. This one is bounded by the common carotid artery superiorly, the inferior thyroid artery inferiorly, and the trachea medially. This is a primary site to look for the RLN because it's often seen crossing or running really close to the inferior thyroid artery right here. These geometric guides allow surgeons to anticipate the nerve's course rather than just blindly searching for it. It's about prediction.
It's remarkable how these seemingly imaginary lines translate into real-world surgical precision, a surgeon's GPS, basically. What about the external branch of the superior laryngeal nerve? The EBSLN, the one affecting high-pitched voices. How is that protected?
For the EBSLN, we primarily look at Jobert's triangle, which is also known as Joel's triangle. Its boundaries are the thyroid muscle superiorly, the superior pole of the thyroid inferiorly, and the sternothyroid muscle laterally. The EBSLN lies within this triangle. That makes this area a high-risk zone for injury. And this directly informs another one of those golden aphorisms. Tie close to the thyroid, not the cricothyroid.
Meaning stay right on the gland when tying off blood vessels up there.
Exactly. When ligating or tying off vessels near the superior pole of the thyroid, the surgeon must stay extremely close to the thyroid gland itself. Ligating vessels too far away risks damaging the EBSLN, which runs near the cricothyroid muscle. There's also Reeves' angle, which more specifically describes that critical zone between the superior thyroid artery and the EBSLN. It further defines that really tight, crucial area that demands extreme caution.
That makes so much sense. It's all about defining these safe zones, these approaches. And you mentioned something earlier, the elliptical angle concept. What's that about?
The elliptical angle contact. This refers to the intricate surgical space right around Barry's ligament. This ligament, it's a fibrous band connecting the thyroid to the trachea, and is often considered the most challenging part of the whole dissection. Why? Because the recurrent laryngeal nerve is frequently hugged or deeply embedded by this ligament.
Right.
It makes it extremely vulnerable. The practical pearl here is to think of dissecting this area like peeling an ellipse.
Peeling an ellipse, like a curved motion.
Exactly. Gentle, curved, sharp strokes that meticulously hug the thyroid capsule. Imagine peeling a grape. You want to stay perfectly on the skin, right? Not tear into the fruit.
Yeah.
That's the kind of precision required. Any aggressive pulling or blunt dissection here risks traction injury or direct damage to the nerve. It's a very specific, high-stakes area where meticulous, sharp dissection is just paramount.
Are there any other notable geometric landmarks? Maybe ones that come into play even if they're less directly tied to the thyroid itself, but still vital for overall neck surgery?
Oh, indeed. And they reinforce how surgeons use the entire neck's geometry to orient themselves. For instance, there's Pyrgos triangle. It's bounded by the posterior belly of the digastric muscle, the intermediate tendon of the digastric, and the hypoglossal nerve. That triangle helps locate the lingual artery. important for controlling bleeding in some broader neck dissections. And then there's the triangle of Baclard. That helps identify the hypoglossal artery. Again, relevant in certain lateral neck dissections for specific tumor resections. They really illustrate a surgeon's deep understanding of the whole neck as this interconnected anatomical map.
Okay, so having explored that delicate dance right around the thyroid itself, we often have to consider what happens if the disease has spread. Which brings us to another critical area you asked about. When and how do we perform neck dissection for thyroid cancer? This sounds like where that oncologic clearance really takes center stage.
You're absolutely right. This is where the strategy becomes very specific, highly individualized. Based on the disease type, it's histology. Our sources really emphasize this. It's never a one-size-fits-all approach. We're not just removing the thyroid now, but potentially also lymph nodes that might harbor cancer.
So before we dive into the when and for which carcinoma, could you first outline the different types of neck dissection? What are the main categories we're talking about?
Broadly, yeah. We talk about central neck dissection, also known as level 6 IT7 dissection. This involves removing lymph nodes right around the thyroid, the prelaryngeal, pretracheal, and paratracheal areas. Basically, the nodes immediately surrounding the gland. Then there's lateral neck dissection. This targets lymph nodes further out, along the internal jugular vein, typically covering levels 2 through V. Beyond these, we have selective neck dissections, where only the specific lymph node compartments known or highly suspected to have disease are removed, targeted. And finally, modified radical neck dissections. These also involve levels 2 through V, but crucially focus on preserving important structures.
Structures.
Like the spinal accessory nerve, SAN, the internal jugular vein, IJV, and the sternocleidomastoid, SCM muscle, unless, of course, they are directly invaded by tumor. Preserving those structures is huge for minimizing postoperative disability, shoulder droop, neck contour changes, things like that.
That gives us a clear map of the procedures. Now, the crucial part, when and for which carcinoma, this is where that personalized strategy truly kicks in.
Okay, let's break it down by the main carcinoma types. First, papillary carcinoma, PTC. This is the most common type of thyroid cancer by far. A therapeutic central neck dissection, CND, is indicated if there's clinically or radiologically proven nodal disease. We call this CN1 clinical node positive. We have clear evidence of spread to the lymph nodes. Now, prophylactic CND removing central nodes even when they aren't proven to have cancer, but there's a risk that's a bit more controversial.
More gray area there.
A bit, yes. It may be considered in specific high-risk situations. For example, with larger tumors, classified as T3 or T4, maybe in patients under 45, or other clinically node-negative CN0 but high-risk cases. But it's definitely debated.
Okay, so for papillary cancer, central neck dissection seems often part of the picture, therapeutically or sometimes prophylactically. What about lateral neck dissection?
For papillary carcinoma, lateral neck dissection is only done if there's proven lateral nodal disease, period. This is a really important distinction. It is never prophylactic for PTC. Our sources strongly emphasize that doing a prophylactic lateral dissection increases morbidity, more complications, more side effects like shoulder issues or swelling, with absolutely no proven survival benefit. So it's not about routinely clearing everything out. It's about a very targeted, calculated risk assessment based on solid evidence of spread to those lateral compartments.
That's a significant difference in approach. Very clear line there. What about follicular carcinoma? Does that follow the same rules?
For follicular carcinoma, the picture is quite different, actually. This type tends to spread hematogenously. That means through the bloodstream, usually to distant sites like the lungs or bones, rather than primarily through lymph nodes in the neck. Because of that pattern of spread, neck dissection is generally not indicated for follicular cancer unless there happen to be clinically palpable nodes, which is quite rare. It's a key example of how the cancer's specific biology dictates the surgical strategy.
And then we have medullary thyroid carcinoma, MTC. Does it behave more like papillary or follicular?
Neither, really. Medullary thyroid carcinoma is different again. It has a high propensity for lymphatic spread, early and often. So, central neck dissection, level 6, 9, and 7, is mandatory for MTC. Even in small tumors, it's almost considered routine because the risk is so high. Furthermore, lateral neck dissection of INCB is performed if nodes are clinically or radiologically involved. Some centers even advocate for prophylactic lateral neck dissection in cases with very high calcitonin levels. It's a tumor marker for MTC, specifically if it's over 200 picograms per milliliter, suggesting a higher chance of hidden spread.
So a much more aggressive surgical approach generally for MTC.
Yes, it reflects the aggressive nature of the cancer, which can also be hereditary in some cases.
And finally, the most aggressive of them all, anaplastic carcinoma. What's the role of neck dissection there?
For anaplastic carcinoma, Well, this is an extremely aggressive form where surgery is rarely curative, unfortunately. Our focus here usually shifts from cure to palliation managing symptoms. Often that means a tracheostomy to secure the airway, or maybe debulking the tumor to reduce its size and pressure effects. Neck dissection is usually not useful in these cases. The disease is typically rapid, widespread, and often unresectable by the time it's diagnosed. The aggressive biology simply outpaces the potential benefit of local surgical clearance like neck dissection.
So it really hammers home the point. It's not about routine, is it? It's about targeted, evidence-based intervention, always with a meticulous eye on preserving quality of life. And you mentioned meticulous documentation of the specific levels dissected is critical for patient care and future review, too.
Absolutely. The consultant pearl here really is dissect only where disease is proven or probable, not by habit. It's about preserving function whenever possible, while aggressively addressing known disease. The importance of preserving structures like the spinal accessory nerve, the internal jugular vein, the sternocleidomastoid muscle, unless they are directly invaded by disease, simply cannot be overstated. A surgeon's expertise truly shines in knowing not just what to take out, but crucially, what to safely leave behind intact.
What an incredible deep dive into the world of thyroid surgery. Seriously fascinating. We've navigated the intense precision required for the thyroidectomy itself, explored that geometric map of the neck with its critical triangles and angles, and really understood the strategic, nuanced decisions behind neck dissection for different types of thyroid carcinoma. This has been a real masterclass in surgical thinking.
Yeah, the takeaway is clear, isn't it? Thyroid surgery is this profound testament to the delicate balance between aggressive oncologic treatment and the meticulous art of preservation. Understanding the specific anatomy, tailoring the approach to the specific disease, it's paramount. It's all about leveraging this deep knowledge, the geometry of the neck, the specific characteristics of each cancer to achieve the best possible outcome for the patient, both in terms of survival and their ongoing quality of life.
And for you, our curious listener, the next time you hear about thyroid surgery, hopefully you'll have a whole new appreciation for the intricate dance involved. So what stands out to you? Is it the almost artistic precision of peeling an ellipse around Barry's ligament? Or maybe that strategic choice. Dissect only where disease is proven or probable for specific cancers. Definitely something to mull over until next time.
And maybe if we connect this to the bigger picture, it raises an interesting question, doesn't it? How much of medical decision-making in other complex fields is similarly guided by such intricate anatomical knowledge and personalized disease characteristics, things often invisible to the casual observer? This complex interplay of anatomy, pathology, surgical judgment. It's truly a hallmark of advanced medical practice, and it's happening every day in operating rooms around the world.
Another fantastic deep dive. Thanks for guiding us through that. We'll catch you next time.